already at that time, we know very much that in the healthy gingiva, that it was concentrated about these gram-positive and facultative bacteria. While if you have a gingivitis situation, there were more parts of gram-negative, but also anaerobes. And if you go the whole way and looked at deep periodontal pockets, it was totally dominating by these red, which is a gram-negative, and anaerobes, which also a good deal was motile. And it was starting the whole discussion where there was definitely so that in the deep pocket there was a change, and now called dysbiosis compared to the healthy situation. But the question was if there was a hen or the egg discussion. What comes first? And it's impossible to answer that question because there is no hen and no egg. It's a parallel situation. So that question can never really be answered. Later on, it was discovered that some bacteria may mean more for this disease situation than others. It was actually Walter-Loesch that's created the term specific plaque hypothesis, saying that some bacteria means more than others. But it was never really proven. It was also modulated a little. And that specific plaque hypothesis has been kind of another type of cornerstone in the discussion of periodontal disease and periodontal disease control. Very much driven by Sig Sokransky, that in the 90s created this color picture, and he picked out 3 bacteria that he called the red complex, and they should be more dangerous to have in the pockets than the orange complex, which also was dangerous, but not that dangerous, compared to the green and yellow and other complexes, which was more related to health. But again, there was no proof if they really caused the disease. And he realized that himself because he made the whole color picture by statistics. So, I handed it.
You can't believe it's
okay, it's okay. Mm-hmm.
It's an appropriate slide.
Okay.
It's this one.
Okay, this one.
If you use this one, you...
Mm-hmm. Now going backwards. Okay. Okay. So statistically, he actually saw that this red complex down here at the bottom was more prevalent in deep pockets than it was in healthy pockets. But that didn't prove anything about the role of these bacteria for the pocket formation or for the disease. Of course, sometimes you can find persons or patients that totally was dominating with one bacteria. And of course, here you can say that in these particular patients, maybe the P. gingivalis was of more importance for the disease than, because this is a picture of a collapsed microbiota. Another situation was seen in some of young individuals. It was called localized juvenile periodontitis, where you actually could find, you can find lesions like this, and it was impossible to say something must have happened here. This is a result of some kind of infection. And when you look at these specific lesions, you find a bacteria called nowadays Aggregatibacter actinomycetum commentans that actually was very prevalent in these juvenile periodontitis cases. And it was also so that if you went to other parts of the world, this is a picture from Ghana in West Africa, which actually was a study created by a colleague, Höglund Åberg, that actually took 500 kids and analyzed them for the clinical data and also for the presence of this bacteria. But it was also so that earlier it was discovered a specific genotype that was more toxic than other genotypes. It was called GP2 clone, and it was only found in West African populations. It has spread, of course, also over to Brazil and Cuba and US, but it was very much related to a specific type of population. And she actually investigated these 500 kids, if they have the bacteria, and if they have the GP2 clone, or if they have the non-GP2 clone, or if they were absent of this bacteria. And then she waited 2 years to see what happened to these kids. And when she analyzed it, you can see that those that had the GP2 clone, they have a much higher number of sites with 3 millimeter or more attachment loss. So you could actually predict that those having GP2 clone when they were 12, 13, 14 years old, they have a much more loss of attachments after 2 years. A minor difference was seen also for those that were absent, but in those that have the normal clone of normal variant of AA, they have also increased a little. But this actually is I think it's a good evidence for that this particular bacteria actually plays a role in the periodontal disease progression, even if we don't really know the mechanisms behind it. So the question was, how do we deal with these patients that have a microbiota with a specific bacteria or not? Yeah, in fact, it was so that most of the treatment was done using the plaque control approach. If that was not enough, people added surgery, so you could do the plaque control and debridement of the root surfaces more efficiently, and also adding antiseptic to it. But the real effect of this specific plaque hypothesis was actually that you can use antibiotics. And all of a sudden it was kind of legal to use antibiotics. But the question is actually what you do with this. Both systemic and local antibiotics was used very, very much, and I think still it is used very, very much in periodontal disease treatment all over the world. But I would like to tell you what could happen really. We did a study in Sweden where we have 16 patients that had a severe periodontal disease. And we said, why not go for the microbiota in the first place, to treat that patient with the goal to eliminate those so-called periodontal pathogens, this specific bacteria. There were 16, and this is the full mouth recordings of bleeding and probing and plaque index. And we followed them for 63 months. That's more than 5 years. And you can see it's beautifully decreased, have a bleeding and probing of 60% of the sites, but it went down the whole way and looks very nice from an overall perspective. 110 sites had 6 millimeter or more pocket depth, which means we picked them up and we recorded them specifically. And of course, 100% had bleeding and probing. Most of them had plaque, of course. And it was also lowered, but not in the same degree as in the more shallow pockets. And this is also looks pretty good, I think, from a general perspective. If you look at the reduction of pocket depth in the red line, or attachment loss change, you can also see that at average, most of the patients gain 1 millimeter more in the deep pockets. And the reduction of the pockets was gained about 3 or 3.5 millimeters. And that also very satisfying from a treatment point of view, unless you look at each individual. Because most people, most of the patients reacted like this. But we had 2 patients that didn't follow the pattern. And the reason for that, we don't know. But you can see here, when we looked at these bacteria, which is the Agrigotobacter, the P. gingivalis, or Prevotella intermedia, at baseline, this patient, number 16, had in all the deep pockets had P. gingivalis. She got the scaling and root planning, and you have some reductions. All of a sudden, the AA pops up, and she got a new scaling and debridement. Then she got surgery. Then she got tetracycline with an antibiotics. And you see, nothing really happens. There are some fluctuations here, but we never get rid of the bacteria. And you can also see that when you look at the average gain of attachment, that she got a little gain the first 9 months, but then she went back to the baseline again. So that was not really, she didn't respond on the treatment. And the other patient was even worse, because she had Agrigotobacter in all the pockets. And nothing happens when we did the treatment. And this was in a periodontitis specialist clinic with very high-skilled hygienists. And it was not possible to get rid of the bacteria. Until after 39 months, she actually lose attachments. And you cannot be in a periodontal clinic and lose attachment. It's contradictory. So we have to do something. And at that time, it was actually so that a Dutch colleague had found out that the combination of metronidazole and amoxicillin had a synergistic effect on this AA, which put her on this combination of antibiotics. And we got, for the moment, or temporary, we got rid of this AA. But it's only temporary, because it was back again after 9 months. Fortunately, we gain a little bit. So she's not in the same situation as she's in the same situation as when we started. But she has one problem. She was a smoker. And that is probably something that we told her. If you don't quit smoking, you will lose your teeth. Because we are not able to treat you. There's no way out. And if you look at the more broader, you can see that some patients in our society, at least in this kind, in Swedish town called Jönköping, there is about 7 to 10% of the adult population, 50 years old, that has a problem. A real problem. They have periodontitis that we not really can handle. In this town, 50 years old, there is no edentulous anymore. But 4% have loss of teeth. 7% have bone loss of 2/3 of the root length at several teeth. These are the really periodontitis diseased patients. Up here, you can see 100% have a dental biofilm. They have a microbiota, of course they have. They also, most of them have bleeding and probing in many sites. I think most of you have bleeding and probing if we should look for it. There's no that have 0. But we also have some bone loss when you are 50 years old. I'm sure I myself have bone loss. I'm 70, but allowed to have more bone loss because I'm older. Because there is a bone loss by age, iatrogenic or whatever. But when you grow older, you lose bone. The question is, what's in this biofilm? You see, there's a mass of bacteria. The whole pocket is filled. And you can never imagine details in this composition. It's more what happens in the biofilm that tells you the activity of those bacteria. And this is just complex picture, but just to remind you, it was happening. There's a lot of processes going on in the dental biofilm. And there's not a matter of which bacteria is there. It's actually what's happening in the biofilm. They're producing acids, they're producing ammonium, they're producing nitrate, and so on. And many bacteria do that. Not one, many bacteria do that. And that creates 2 main metabolic pathways in the oral cavity. One that is defined by the sugar and access to sugar, which is the saccharolytic pathway, producing lactic acid, and finally may have impact on the caries and caries process. While if you have a proteolytic activity, which is the most dominating metabolism in the gingival pocket or the periodontal pocket, creates a lot of different acid, ammonia, sulfur products, and so on. And the pH is higher than 7, which means now you also get mineralization, calculus. And we think that the calculus is very much associated to the periodontal disease problems. Another thing that was also said, that the activity of bacteria. So Kransky actually formulated the so-called burst theory, where he found that some bacteria may colonize, and all of a sudden they grow. They overgrow and cause active disease. That was never proven, and it doesn't mean that these activity peaks can be very small and happens very often, but it was a relation to the bacterial activity, not the composition. So what actually periodontal disease is, should be looked at, is that it is a breakdown of the balance, the homeostasis between the host and the microorganism. And the balance favors the activity of bacteria. They're producing a lot of different things and they change the ecology of the bacterial pockets. So the ecology is self-generating in many ways. I will just hesitating to show this maybe a little complex figure, but this is actually the model today for how we look at the pathogenesis of the periodontal disease. It was created by Korn and Page in '98, and is still the model today. Where you have the microbial challenge here with growth and the change of the ecology, which actually increase the release of microbial products, and the host will respond with an inflammation. The magnitude of that inflammation is dependent on environmental factors. That could be smoking, or acquired risk factors, could be a disease like diabetes, but also by genetic risk factors. And all these factors together will influence the magnitude of the host response. And it's and if that host response is standing for a long time, or the magnitude is high, that creates a secondary effect on the bone and rest of the body. But it's still, the key point here is that the role of bacteria is to creating the inflammation. Several researchers have not really accepted that. They think that the bacteria, and some bacteria, has a key role in the periodontal disease. And that's why the keystone pathogen hypothesis was created some years ago. It will be very, very difficult to prove that this keystone hypothesis really have some impact. I don't know how they really want to show that this is something. It's still an hypothesis. We don't know the role of the bacteria. It was also clear that other things, as I said in the Corman and Page model, that diabetes and smoking and genetic polymorphism have something to do with the periodontitis. But it's still not really proven what's in the genetics that has any impact. It's looking for a lot of genes, but that's not the way to do it. It's probably a very, very complex situation. So it's not really possible to find it out. So if, to summarize a little bit about the periodontal disease control, you can look at that as a marginal periodontitis is associated with a dysbiotic microbiota, is not something that is there when you're healthy, but it will develop when you are diseased. And the really important thing is that the periodontal pocket is an open system. You can never have a goal to get rid of all the bacteria. That's not possible. It's an open system. The bacteria will come back sooner or later, rather sooner. So this this actually implies a distinct goal of strategy for treatment. The rational goal for treatment of periodontitis is to seek control of the disease, not necessarily to cure it. The goal is to restore the ecology balance between the subgingival microbiota and the host. That is consistent with periodontal health. And that is, of course, limits the way to treat patients, of course. Again, infection control, as it's called right now, or plaque control, will still be the cornerstone. The oral hygiene in the patient will still be the way to come out, to reduce the inflammation as much as possible. That is related to self-care. It's a daily oral hygiene procedures that is important. And that is on the patient. The patient has to be to get the knowledge and also to get instructed how to do it. But it's very much related to the patient's skill or interest actually to do that. Of course, the patient can get help if you need to get rid of calculus and think that's the dental hygienist today. Sometimes you need surgery just to be able to clean the teeth more better. That will be the periodontal specialist. But what is the role of the dentist in periodontal treatment and prophylaxis? That is the question. And that has been tested in this town called Jönköping. They actually did that for 40 years. Every 10th year, they examined 1,000 patients in different age groups for a lot of different things, a huge number of different things. And every 10th year, I have just picked up 73 and 2013, but there is also in 83, 93, and 2003. But just to contrast what was the situation in 73 compared to 2013, you can see that the total number of edentulous patients, those that was 70 years or younger, there were 63 in 73, no one in 2013. Number of teeth in the 70-year-olds, there was in average 13 teeth compared to 2013, 22 teeth. Number of filled surfaces in the 70-year-olds was 37 surfaces compared to 45. That have increased. And that is, of course, due to repairing from those that have a lot of fillings or crowns. Because if you see on the 50 years old, they reduced from 48 to 22 or 23. 30-year-olds reduced from 46 to 7%. Of crown teeth in 50 years old was 24 in 37. They almost all have it. Now it's only 3.7%. Of total number of tooth surfaces with plaque was 44. Now it's 15. So a huge improvement of our hygiene procedures, the self-care. And percent of endodontically treated teeth was 17% of endodontically treated teeth, 17 compared to 5 in 2013. So there has been a very striking change of the whole dental situation. through these 40 years. This endodontic situation is a nightmare, actually, because if you go internationally and look what is the endodontic situation, you can see here in a study from different countries, starting with Denmark here, of those teeth that are root filled, the prevalence of an apical periodontitis could be much variation how you define an apical periodontitis. But half of the endodontically treated teeth in Denmark was actually having an apical periodontitis. So if you have an optical quality of that endodontic treatment, technically, it's only 1/3. But if they are poor quality, 78% had apical periodontitis. That's why we should not think that endodontic treatment is just a technical thing, but we have a tendency to think so. In many other countries, the situation is the same. And we all see this with poor endodontic quality. They have much higher degree of apical periodontitis. So you can imagine, what are the dentists doing, really? They're doing the bad endodontic treatments. That is the situation. And also here from Brazil, it looks like it's pretty good here. It's only 16%. But you see with those with poor endo, it's 71%. And in Colombia, 49% of endodontically treated teeth have an apical periodontitis. 67 have a poor endo. So hopefully we don't need endodontists anymore, because they cannot really handle it. We cannot really handle the endodontic treatment. But the interesting thing was, when you go back to these Jönköping studies, that in 73, you can see 10% had a healthy gingiva of this whole group. Like 40% have gingivitis, almost 48% had moderate periodontitis, and a small group here of 5 to 10% have severe or advanced periodontitis. That changed over time. And you can see here, when you come down to 2013, that now we have a big group that actually have healthy situation, gingivitis and moderate. And that's, all these sectors have decreased through these 40 years. The only one that remains in the same situation is the group with severe and advanced periodontitis. So during these 40 years, we obviously could not handle those patients with periodontitis. And that leads them, and I think that is also a good conclusion for my presentation, is that the continuous improvement of oral health and the reduced need of restorative treatment will seriously affect the provision of dental health care and dental delivery system in the near future. And I think that is something that has to be realized also in our society, in a country like Sweden, that we face a situation where we don't need so many dentists. That's my final comment. Thank you very much.